I appreciate the opportunity to present this work, and thank you very much for the kind invitation to come to Brazil. Autologous cartilage transfer techniques. Chondral lesions are very common. They've been reported in almost 60% of all knee scopes. Osteochondral defects are in 19% of 1,000 cases reported, and the mean defect size was about 2 centimeters in square. The medial condyle is the most common site for these defects, and the ICRS grading system of 3 and 4 was present in 7% of 1,000 scopes in patients under 50. So this is a common problem. The articular cartilage injury occurs in conjunction with the anterior cruciate ligament tear in a significant number of patients, and in the Norwegian ligament registry study of almost 3,400, almost 3,500 patients, 26% of them had cartilage lesions. And importantly, the incidence of these cartilage lesions increased 1% per month from the time of injury until the time of surgery. So it seems like something is going on with these cartilage problems. The theory is that the initial injury is irreversible. And there was a study that was recently reported that showed 23 patients with an osteochondral lesion on MRI. At 6 years follow-up, the signal marrow change had persisted in 65% of these. So the feeling is that articular cartilage progresses. Articular cartilage damage progresses. It worsens with the cyclic loading from fibrillation to fragmentation and to delamination. So when does this kind of injury occur? Does it occur at the time of the ACL tear, or does it happen later? Because often when we're scoping a knee, we get in there and we see these. So notice that this tapers to the center, to the intercondylar notch. So my donors and recipient sites are going to be adjacent to the area where the curette is right now. I'm freshening up the edges, making sure I have vertical articular cartilage walls, making sure to scrape any residual articular cartilage off the bed. Then I come immediately adjacent to the articular cartilage with the fluted drill. This carries away the bone that's removed nicely. It has a tip on the end, which once you impact it into the spot you want it to go, it's not going to migrate. Again, maintain your perpendicularity to the adjacent articular cartilage so that once you've got this recipient site placed and then you harvest the appropriate plug, all the articular cartilage will be parallel with one another. We're placing our second recipient site. There's about a 2 or 3 millimeter bony bridge between the two to allow for a press fit. And then once we've got those in place, we're going to go to the harvest site. In this instance, we're going to use the harvester. We're going to go down to about a 15 millimeter position. We have measured how deep we were going on the drill because the drill also has these laser lines, and you measure your drill adjacent to the articular cartilage. You put this in, the harvester in, you rotate it 2 full turns, and then you pull it out. And you don't have to worry about how much bone you've removed with this particular system because of that tooth that underscores it always allows you to have a great cut. Now we're on the back tail, on the Mayo. I'm putting the harvester into that retropulsing device, and I push down, it pops, and then it pops it back into place. We remove the harvester, exposing the inserter, and you can see down on the left lower quadrant how the articular cartilage is a nice, smooth, non-angulated coat. And then we go ahead and insert this through the portal through which we created the recipient hole. Again, the gradations on this inserter show it's a 15 millimeter depth plug, and then we just tap on the blue insertion plunger very lightly with a mallet, and this is dramatically less pressure than with any of the other insertion systems. And once we have it to the right level, we back off and adjust and see how this matches up with the adjacent articular cartilage. If it needs a little tap more, then you've got it in place. So we go back and we get our second graft since we have 2 recipient holes. We'll go ahead and go down to the 15 millimeter mark, which was the depth that we drilled on this one, because we're replacing a little bit of bone. Rotate it 2 full turns, back it out. You don't toggle or lever it because that'll break down the walls of your recipient, of your donor site, and then place the second one. These are 6 millimeter plugs. I like to use 6 millimeters because it's a small, minimally invasive defect on the femoral condyle, which I would otherwise just leave alone. The postoperative protocol is immediate early motion, non-weight bearing for up to 3 weeks, progressive weight bearing between 3 and 6 weeks, and then full weight bearing after 6 weeks with a progressive rehabilitation program. We usually get athletes back to pivoting activities at about 3 to 4 months. This is our clinical experience with my colleague, Dr. Jimmy Chow. We reported on 36 patients, an average 4-year follow-up. Lysome and Tegner scales were positive on this. I'm not the only one who's doing this. Dr. Hangety has reported in last year's AJSM a 17-year prospective multi-center study of over 350 patients. Good or excellent results were observed in 91% of the femoral condyles. The outcome seems to be correlated with the lesion location. The medial femoral condyle does better than all the other sites, such as the patella, the trochlea, or the tibia. Well, what about ACI? There's been a comparison, one report in the British JBJS comparing ACI with autografts. They reported that the autograft had good or excellent results in 69% compared to ACI having good or excellent results in 88%. I would point out that their average defect size was 4.66 square centimeters. Now remember, one of the first slides I said was that the maximum size that you should be using this on is about 4.9 square centimeters. If their average size is 4.7 centimeters, that means that there's a selection bias in this study. They were using these autograft transfers on larger lesions than I would recommend. And when you look at Dozen's 2005 study, in which he had smaller mean lesion sizes, the results flip-flopped. 88% autograft having complete recovery, whereas 68% of ACI having complete recovery. Chondral defects in athletes, in a systemic review of 11 studies comparing a variety of different treatments, ACI and core had better outcomes than microfracture. Core had the core autograft had the fastest sports return, ACI had the slowest sports return, and the microfracture results deteriorated over time. In a level 1 prospective study in the pediatric literature about osteochondritis dissecans with a mean 4-year follow-up, the core compared to microfracture had better clinical results and had better MRI results. Marrow stimulation, a systematic review, showed improved function in the first 2 years, but the durability was questioned because of limited hyaline tissue, the variable nature of the repair cartilage volume, and the possible functional deterioration over time. ACI versus microfracture, no difference in groups at 5 years. So if the microfracture doesn't do well at 2 years and begins to deteriorate, and at 5 years is not doing so well, and you compare ACI to microfracture and there's no difference, it makes me wonder how effective ACI is at 5 years compared to a chondral autograft transfer. Technical points. It is really important to make sure that your graft is flush or only slightly sunk. If it sinks over 2 millimeters, you're going to get some cartilage necrosis and fibrous overgrowth. Proud grafts are bad. They get fissuring, fibroplasia, and subchondral cavitations. You want to equalize the pressure. Remember, pressure kills cartilage cells. And Brian Cole did a study in which he showed that the insertion force damages the articular cartilage, and cell death is higher in the superficial layer, and the children, the immature cartilage, such as with OCD lesions, have a greater cell death at impact than the mature cartilage. And what is most compelling is that death varies logarithmically with the impact energy. The impact force is more important than the impact number. So we did a study using a foam bone as a protocol and compared all the different devices on the market, core, oats, mosaic, plastic, with a single impaction. And we found 3 statistical groups. The new core system that I'm talking about now, the 6, 8, and 10 millimeter diameter probes, grafts, were in one statistical group. The mosaic plasty and some of the oats were in another statistical group, and the larger oats cells were in yet another statistical group. Now, in the oats system, the technique calls for something called compaction. What they want you to do is take a graft that is 2 millimeters longer than your recipient site, push it in, and compact it. And if you do that compaction technique, then that increases the 6 millimeter, the 10 millimeter, and the 8 millimeter impaction forces significantly. So in conclusion, the factors associated with a successful autograft transplantation include age, BMI, alignment. I think microfracture is the appropriate treatment for lesions under 10 millimeters and in patients under 30 years of age. The core transfers would be for lesions between 10 and 2.5 centimeters, 10 millimeters and 25 millimeters in diameter. If that fails, allografts are the secondary treatment. But remember, pressure kills these cells. Do not compact the graft and make this as low an impact transfer as you can. Thank you for your attention.